I'm speaking with Professor Paul Peters from the Department of Health Sciences at Carleton University in Ottawa, Canada. Welcome, Paul.
Good day.
So recently you've published a paper in Rural and Remote Health, Patient and Provider Perspectives on eHealth Interventions in Canada and Australia. I wonder if you could first start by introducing the co-authors.
Yeah, thanks. Well, I'm only one of the co-authors on it, as you mentioned. The lead author on it is actually Michelle LeBlanc. She was a research assistant here at Carleton University, a tremendous young scholar. And then as well, a PhD student, Sam Petrie, again at Carleton University. And then we had another research assistant who participated as well, Sambhavi Paskaran. And then we're joined by Professor Dean Carson from Central Queensland University.
Fantastic. So what is eHealth?
Well, I mean, the eHealth has a lot of different definitions. And so we all sort of have a rough idea of what we think eHealth is. And in rural communities, it is slightly different than what is often talked about in the literature, in sort of the media. So what we really mean by eHealth is we're focusing on the actual provision of care via electronic means. So that's either telephone or voice only over internet or virtual with including video in that. But generally in terms of provision of care, in terms of eHealth, we weren't including some other aspects that often are included, such as electronic medical records or electronic medical education. So we didn't include that. It was more about provision of care.
Mm-hmm. Right. And what did you find?
Well, we found that eHealth has been studied and attempted to be implemented for a long time. And this paper is actually quite timely given the onset of the global pandemic. So we had been studying eHealth for about a year and a half and doing this scoping review, essentially trying to look at the benefits and disadvantages of eHealth for rural communities. Because eHealth sort of been described as a situation of perpetual pilot projects. There's always pilot projects for eHealth going on, but nothing ever comes up into some sort of eHealth system, right? It's a patchwork all over the place. So we wanted to look at, well, why is that the case? And so our paper took a little bit of a unique focus in that we wanted to pull out those articles where they had included the patient or the provider voice. And they'd done qualitative type analysis. And so what we were doing is we were pulling out from papers via scoping review the perspectives or the voices of patients and providers that were within that. So it's a little bit different. So rather than actually going out and surveying people ourselves, we looked at those papers where they had done that. And so one of the things that we found is that it had yet to go into a sort of full system. Although now that we've seen a global pandemic, all of a sudden overnight, people switch over to eHealth, where that's the primary means of delivery of point of care, right? So for consultations anyways, and even for specialist appointments. So it's interesting that all this research was done prior to this, but I think a lot of our stuff really points to some of the advantages and disadvantages. They're what you would sort of think. Rural patients particularly liked it. It saves a lot of time, right? In travel, it's much more flexible. They also found that they could see people quicker, generally, and things like that. Providers also liked it for very similar reasons, right? So they were able to, to find things that they also really liked. Some of the disadvantages, however, they felt are really technical. Is some of the biggest things is that rural Australia, rural Canada, and rural Sweden, where we sort of focused our research, was in the same boat. Rural internet is slow and unreliable, right? You get a cloudy day and internet slows right down. Or you get a storm come through and it might be out for a day. So these sort of things happen, and it's just technical. And even then when it's on, it can be patchy and up and down. Also technical in terms that, people use different systems. The providers weren't always up on what systems. That has now changed. We're doing some rapid reviews that are going to be looking at that, and providers are now going to these sort of things. So we really found that there's this area where it's really ripe for implementation of eHealth within local communities. And the barriers were largely speed of internet, but then also buy-in from rural providers. So, and that buy-in was for a number of means, but they were sort of saying that, it didn't fit with the systems they were doing, but also the remuneration from the government isn't always as high. So the systems weren't in place, right? So they didn't have one eHealth system that they could log into. Everyone had to find their own. And then when they were using it, they weren't paid as much per patient as they would otherwise. So there wasn't, even though they find that it might take more time, right?
Yep.
So these sort of systems just weren't in place. It wasn't a cohesive. So physicians and clinics were trying to put it in place, but they didn't necessarily have support of the larger state or national government, whichever you're dealing with, or province. So it was this coordination between this. So really it was systemic factors that were the problem. And we put internet down to a systemic factor as well, right? Australia and Canada are both in the same boat where they promised fast rural broadband for how long, right? I don't know how long. Yeah. I've been studying this since the early 90s and been promising since then. So yeah.
Yeah.
Anyway, those are some of the barriers that we found. But we found overall that actually patients and providers preferred having this option. And in most cases, it was a preferred option.
Yeah, yeah. So where to next for eHealth? What do you think is the next hurdle to overcome?
I think the next hurdle is, I think a lot of it's been overcome with the current pandemic.
Yep.
In that there's been massive buy-in, in that people who wouldn't have otherwise started it are now doing it. And now you're starting to see some of the higher levels of government, so either the state or province level, who are responsible for doling out the care, starting to actually change some of their processes, putting in the correct billing codes, having a preferred service for it. Pharmacies are now having improved electronic submission, right? Rather than faxing in prescriptions or something god awful like that, right? So these sort of things are starting to come together a little bit. But I think that's really the next step, is ensuring that those things that the medical associations, the physicians, advocacy associations, and the patient associations have been calling for well over a decade, that those things actually are codified. And I think the pressure needs to be kept up, because rural communities really stand to benefit of that. And when they do that, they need to then consider rural separate from an urban solution, right?
Yeah.
Because we've really found that rural communities, there's a need for much more flexibility in terms of, you've got clinics of different sizes. People might be 1 week one place, 1 week another place. They might be on locum, a traveling physician. So, people might not have one family physician. They might only go to we call them emergency rooms here, but, different things in different countries. That might be their primary point of care. Yeah. So, it might be the clinic. So we need to be able to have flexibility in the health systems when they're developing the policies, and make sure that it's not just an urban approach placed onto the rural, that it's developed by, the rural docs, the flying docs are the ones involved at the table in developing this, right?
Yeah, yeah. Well, this is a really fascinating study, and thank you so much for talking with me about it.
Thank you.
All the best.
Yeah, cheers. Thank you.